So this is another episode of Sonographers After Dark. I am joined by Dr. Judy Hung from Mass General Hospital in Boston. So, well, first of all, thank you. I really appreciate you being on the show today. So,
no, it's a pleasure being here, and I've always admired what you do and what you're doing for your sonographer colleagues with this podcast.
Thank you. I appreciate that. Judy, we're going to talk about all things valvular disease today, right? I mean, that's kind of what we talked about. So, welcome.
Thank you. Lots to talk about valve disease.
Yeah. So I have a few questions for you. They're probably loaded, right? So first of all, I was watching an aortic stenosis ASE talk, and this was years ago. This was probably, I don't know, 2015 maybe. So it's been a little while. And somewhere I thought I heard you say that you have goats at home. Did I hear that correctly?
I don't have goats.
No?
I have donkeys.
Donkeys. Oh, okay. Donkeys. So
yeah.
I want to ask about that.
Donkeys.
Nice. There we go. Yeah, I can kind of see it. Very cool. How many do you have?
No, I don't have donkeys. I have a neighbor friend that has a farm, and he and his family have donkeys and other horses, and they allow me to come visit and pretend that donkeys are mine.
Yeah.
It's really just a form of therapy. Equitherapy.
Yeah.
Some people have like cat therapy. Well, yeah. I do equitherapy.
Nice. I have chicken therapy, so I have 4 chickens.
That's exactly what it is. I thought about chickens. What do you think about chickens? Are they hard to take care of?
I mean, they're not hard. They're a little gross, quite honestly. So gotta constantly. I'm a little bit of an OCD germ freak, so I have to constantly. Yeah, but they're really not hard to take care of. They're fairly easy. I only have 4 of them, so I think if I were to have a whole huge flock, it would be challenging. But and I'm not really traveling like I used to. In the past when we've met up, I've been at your institution or somewhere else, anywhere in the world. And so with my role in industry previously, so now I get to be home a lot more. So because of that, they're not too hard to kind of incorporate into my life, and they're cool. I talk to chickens, so yeah.
Well, I really like the way I own my donkeys. Basically, my neighbor takes care of it, and I get to pet it and feed it carrots.
Reap the benefits of it, right?
And then I leave.
Yep, that's the best kind of donkey to have. So, yeah, awesome. So, with that, I have just a couple questions for you because I want to try to understand and have our viewers. This is primarily sonographer focused, right? So, I know you work a lot with training fellows and residents and the physician side of things, but you also work with some very high level sonographers in your institution as well. And so, I guess I kind of want to understand. What really drew you to kind of specializing in valvular heart disease, and what brought you to the place where you're really the expert in that?
Yeah, no, I think it's really what brought me into echo. It's a great way to understand and examine physiology, cardiac physiology. I think it started out in the cath lab where you stuck catheters in and measured pressures. Yeah. But what you can do using ultrasound to really understand cardiac hemodynamics is it's sort of replaced the cardiac physiologist. So that's what attracted me. And I think valve disease is just fascinating from a sort of a mechanistic and physiologic standpoint. And it's also it's a very important problem, and just the prevalence is just going to exponentially increase as our population increases. So, I mean, one good thing is that we are aging longer, but we also will have to deal with other, probably more chronic conditions. And a big one's going to be valve disease.
Yeah, agreed. So, I actually started a ACS track, like a mastery class that's doing, right now we're in our 12-week
Right,
course. So
right.
we are reviewing pressure loops, PV volume relationships,
Yeah.
all of that. And so, it's a good reminder for me because it's been a little while, right? So I'm like refreshing my own memory on that. But, it's so relatable. Like you really can with Doppler be able to understand what's going on with pressure changes and volume relationships too. So, and I think sometimes maybe some sonographers get into that habit of picture taking instead of really thinking through that process of the physiology behind it.
No, that's I'm really glad you emphasized that point because it's not just about getting the images. For I think when I speak with my sonographers, it's not just the image taking, but it's also understanding the physiology that attracts them to this field. It's figuring out the flow patterns and whether this is truly hemodynamically important stenosis or important regurgitation. I mean, that's really what we're tasked to do. And it really starts with the sonographer.
Yeah. So, with that, I know that you have some sonographers in your facility that are high level, they're advanced, they're doing some research and they're doing things that, maybe some other sonographers don't get an opportunity to do if they don't work at a center like MGH, right?
Hmm.
So what would you say, from your perspective, is the most common pitfall when we're looking at valvular echo assessments that maybe some sonographers who don't have that research background can be on the lookout for?
Yeah, no, I think and it kind of depends on the valve disease, but a common pitfall for aortic stenosis, for example, is not getting multiple views and it, certainly going for the parasternal views because often they can be higher. And I just ran into a case last time where they one case they didn't use a non-imaging probe, and that particular just made a big difference because you went from a gradient of like 64 peak to 40, obviously a big difference in the interpretation. So things like that, making that it's just those things are just really important to do, especially when you have significant AS. I mean, sure, yeah, if you can tell the leaflets are opening fine, but when you're in that, marker where you really got to figure out is it significant or severe AS, those things are so important. And for MR, it's sort of the same thing, paying attention to uh, getting that proximal jet and making sure you zoom and baseline shift for the PISA for the quantitation, things like that. So it's all about just sort of knowing what's really important for the assessments and the quantitation for each of the valve regions.
Yeah. And I think as we're moving, we're in this kind of TAVR world at this point, right? So,
Mhm.
when we've moved into some decision making for the heart team, how does that high quality echocardiography really direct and influence those decisions?
I cannot emphasize how critical it is. That's they're looking at the echo to make these decisions.
Yeah.
So it's so I mean I don't know how to say it more bluntly than that. They're
Yeah.
looking at the echo. They're saying, okay, are we? What's the decision driver to decide whether replace the aortic valve? It's all based on the echocardiographic data now.
Yeah.
So I mean, as I said, I can't emphasize how important it is to get high quality echoes. And as I said, it's really we depend on our sonographers to do that for us. We're not the physicians aren't scanning, at least in the United States,
Yeah.
and that's we emphasize that, and that's why we really um, put a lot of effort into training our sonographers and also continued education as well because they're really in the front line.
Yeah. Yeah, and I think, and this is a conversation I've had. I spoke with Amy Dillenbach not too long ago from the Cleveland Clinic,
Mm.
and we were talking about kind of how do we get sonographers to that place where they are more advanced, right? I think you obviously have a team that has a good training program in place, but for those sonographers who aren't in a center of excellence like yours, and we were talking about the ASE and just really advocating for ASE membership, ASE involvement, and really growing your career with the ASE as well. So obviously, I know you're passionate about that society also. So
Sure. No, and I think I'd like to approach that question in maybe two parts because, um, and importantly, I think we have a broad spectrum and range of echo labs, and some are more office based, and some are places like here where you have, a huge department uh, doing echoes with a lot of resources. All right, and so I think for both those types of practice, the ASC does provide an important educational uh, home or place. I mean, that's really one of the critical missions of the ASE is that you can get the guidelines there. They have teaching modules and micro learning opportunities as well as the courses and scientific sessions. So that's a great professional society for that. Um, one so but one of the other things I think you can do even at your own place where you are is we created different career tracks for sonographers. So they're not just stuck at you're just sono 1 and 2 and 3, and then the only difference is how many years you've been there. So
right.
we've created career tracks where you're more more of administrator, where you triage and the studies and workflow and operationally. And then we have also one where you're more an educator and train and teach. And there another one that we're trying to create is one where you're almost more like the concept of advanced cardiac sonographer, where you're very, more independent about even the interpretations as well. So I think that's very important is to offer these pathways for sonographers and they can choose. There's some people would rather, be more into the research aspects. And I think that creates a more fulfilling career path for sonographers and it keeps them engaged as well. So I think that's an important part. You can even do this at a smaller level in maybe more of an outpatient practice as well.
Yeah, and I think keeping sonographers engaged is important because uh, that's a challenge, right? Because
Yep.
then you have retention issues if you don't. And
Yep.
so, I think staffing shortages are across the country. And so that's one thing that came about with COVID. And I know you actually were the president of the ASC through COVID. So you kind of got this unfortunately the short end of the stick when it came to presidency of the ASE. Everything went virtual on your watch and you kept it afloat. So we'll talk about that in a minute. But I think that there's also a shift with sonographers in that moment as well, and how they learn and then also how they work within the lab. And so there have been so many staffing shortages. And how have you dealt with that in your lab?
I think we've had the same staffing shortages that have been experienced by practically, cross country. It's just um and how we dealt with it. We paid attention to um creating different career paths for sonographers so they'll be more engaged and for retention. It's not just the same old again. They have various career paths that they can do. We've also been more flexible in terms of sort of how the work balances, hours are, etc. It's not just, they have to be here from 8 to 5 every day. And so I think those are all important things that we've done to retain. But it's frankly, I think the issue with the shortages, Lara, is that this is just catch up for us. I think we're realizing as we realize the value of echocardiography in healthcare. That it's unfortunately, whether it's good or not, but it's a lot of people are just defaulting to getting an echo and not paying so much attention to the physical exam, whether they're not teaching it as much anymore. So I just think we just need more sonographers because this test is going to be needed to be more accessible. It's going to replace a lot of sort of I think standard initial exams.
Yeah, and I
So
think a lot
that's going to
of
increase.
focus has replaced
Po
some initial exams as
Focus
well.
focus will, yeah, but I do also think that it's just a question of, hey, we we have a great exam that really it can tell us a lot about cardiac function and structure. It's non-invasive, and it can be everywhere. I think with our issue is just that we don't have the manpower yet to fulfill the demand. And I think I'm hoping that eventually AI actually will help in that it will make the sonographer's lives easier, both
Yeah.
in terms of sort of the assessment, prelim, and scanning.
Yeah. And there's so many different AI softwares out there capable of all of that, right?
Right.
A lot of vendor agnostic ones as well. So it's not just vendor based. There are systems that are put out also now on the market with very robust AI packages also. But I think that as we move to a lot of those vendor agnostic type of platforms, that also helps to be able to just kind of widen that broad use of AI, right?
Right.
So then I think that there's a lot of fear around that though,
Yeah.
because
I don't,
others don't
I
want to
think
lose
it's
their
going to be,
jobs.
yeah, no, I know everyone's actually understandably concerned about that, but I actually think it's going to create the opposite effect. We're going to
Mhm.
need more because what now we realize, okay, we we have better ways of providing this test or greater access to this test to people, and we're just people are going to think of it like a chest X-ray almost, although it's much more complicated than a chest X-ray.
A little bit.
Yeah,
Yeah.
but because of that, I think the demand is going to grow, and we're going to need more people because more people are going to be getting this exam.
Yeah.
They are,
Yeah.
even as a baseline.
Hmm.
So, I actually think our volume is going to grow. We just haven't been able to catch up with it.
Yeah. I think we're still
Uh,
catching up from COVID.
yeah, because honestly, we need to train more people to
Hmm.
do this.
Yeah. So one of the things that I started doing is an crossover program for sonographers who have maybe a place that they can learn the hands-on portion and have some support, but they need a foundational, didactic
Yes,
base, right?
yeah,
And
that's very
so
important.
yeah, so they might do general ultrasound, but now they're in this rural hospital and they have to do everything and they're expected to learn echo, right? Like how do you do that on the job, right? In the past that was different, but in today's world that's a little challenging. So I started doing this didactic program that's like 12 weeks long. They can at least learn the basics and the foundations, right? So I think we're going into this more of like an online learning type of environment, and there's
It's
programs
all
that are
online, right,
yeah, that are
Lara?
yeah, yeah. Well,
Yeah.
then there's like a week, just get your basic views, understanding,
Okay.
hands-on option for it as well. But obviously, they need full support, from their site to learn fully how to scan. But it kind of helps to bridge the gap between taking a sonographer who doesn't know echo but knows all the basics of physics and basics of ultrasound into starting to learn echo. So, and I think there's like 1 year. Certificate programs out there online as well. So what are your thoughts about trying to incorporate that into some of the things you're doing or other labs
We're
and
trying to do all of that. As I
yeah.
said, we have a shortage of sonographers. We cannot get enough sonographers because we have so much demand. And again,
Hmm.
the demand I really think is a reflection of a change in practice. People are realizing and going to let's get an echo,
Yeah.
because for whatever reason they can't do the physical exam as well, or they've realized this is it's a great test. It's a great
Standard of
diagnostic
care.
test. It's
Yeah.
yeah, it's almost becoming that. And
Yeah.
as I said, I think think we're going to go toward that kind of
That
perception
you get an
more and more.
echo and you get an echo,
Well,
right?
yeah,
Yeah,
and we can make arguments about whether that's necessary or not, but basically, I think that's what's happening, at least
yeah.
in the hospital and all that.
We're talking about it
Uh,
kind of being the standard of care, and then also incorporating the like some
oh
cross
yeah,
training options
oh yeah.
and what that looks
So
like.
yeah, so we
Yeah,
as I said, we have a huge shortage. We're trying to do. We we can't hire them fast enough from the schools, so we are exploring collaborations to do the 1 year internship programs that,
yeah,
that we would provide. And I know a lot of other ACMs similar to us have already started these type of programs just so they
yeah,
can get more people, um, uh, more people in the workforce for them. As I said, I
right,
really
yeah,
think we're in a catch up phase. You know, we can't get
yeah.
enough, and that's probably true for all. I think cardiology related technical fields in
And
general.
that's what Amy and I were discussing about the Cleveland Clinic because they started this kind of homegrown echo program, right?
Yep,
And she was
yep,
tasked to get that off the ground. And so, I think a lot of hospitals are transitioning to that because it builds in their staff. They're training their own staff, and you have a supply of sonographers. So,
absolutely. I mean, as I said, we compete. We have two schools schools who will give also a bachelor's degree and a sonographer certificate. We compete. There's only two of them, but we compete with what 10 hospitals to get
yeah,
them.
yeah, that's a
So
lot.
yeah,
Yeah,
but
especially
I
in
think
just Boston area. Yeah,
oh yeah, they can pretty much go anywhere. And
yeah.
so I would just give a plug for it's a great career to go into. Only there's such a demand, and I just don't see it ending.
Yeah. And
So
that brings us to some of, you were talking about that potentially becoming a standard of care. So then how does that fit with like appropriate use criteria, right?
yeah, yeah. No,
What's that balance?
I understand. I understand, and I think you know I think care has changed just because the nature of medicine has changed.
Mhm.
We the training for medicine has changed to more it's much more perhaps shift based. I don't know. It's a so that's changed. I do think honestly there is a less emphasis on physical exam than previous. And
Yeah.
I don't think that's I think the reason for that is there's just so much data available to us now. I mean, not only is there the physical exam, we get all the complicated laboratory data, all the complicated imaging data that there, wasn't available 20 years ago. I mean, 20 years ago it was the physical exam and some labs.
Yep.
And so our technology has advanced and my I think because of that, we actually have advanced and improved our care for our patients.
Hmm.
We're not just stuck with labs and an exam anymore. I think we can diagnose faster, and so I think that's all a good thing. And I think a part of the reliance on echocardiography is part of that.
Yeah.
Yeah,
Yeah.
it's just part of the technology advances that we have been fortunate to have, and it's making that technology more accessible.
Yeah. And and accessibility extends to beyond the sonographer, right? So we're in a place where I think our learning methods have to adapt to
Yep,
what is
different.
currently
Mhm.
needed in the environment that we're in now. So
Yep, no, absolutely. And I think it's just medicine has evolved and how we care for patients has evolved. And I think a
yeah.
lot of that is technology.
Yeah, definitely. So
Yeah.
when you were, I know you navigated some really troubled waters of the 2020
Yeah.
presidency of the ASC through COVID. And so let's just talk. I mean, I know you've probably shared a lot about that, but let's just kind of hit on that a little bit. Some of your priorities that you had then and how you've seen those grow beyond, now that we're a few years past that time.
Yeah, I mean, I can give you my sort of perspective on now that I have am past the PTSD of COVID. Because you can imagine. So I came into the presidency June 2020, right? End of June 2020, and of course the whole COVID thing blew up in our country. What, March 2020?
Yeah.
And I I am not going to take any credit for how well the ASE responded. First of all, my predecessor, Madhav Swaminathan, was the prior president. I mean, he was thrown into this mess during his presidency. So I was able to he had already set a lot of the stage for how to manage this. And I would just attribute it to how phenomenal the ASE staff were in realizing what was going on, what was going to happen, and executing the plan. They basically said, "Okay, we will no longer be having any in-person meetings at all," and they managed to um, get the scientific sessions to pivot to that, to get the online platform to hire that, and
Do it fast too. Yeah.
renegotiate with all the hotels that had to all be renegotiated. And I was just astounded at how well they did. And what it told me that is that I think it's a really important lesson is you know, really, life is hard, right, Lara? Life is always hard.
Yeah.
And you never know what's going to come at you.
Nope.
And yep. And I think the best approach is to learn that you need to adapt and be able to adapt, which is exactly what the ASC staff did.
Yeah.
So I was just really proud of them for not like having a total freak out, which they wouldn't anyway, but say, okay, this is the reality now. How are we going to handle this, and how are we going to manage it? And
And
they
I think
did.
at least they had time to adapt, right? They had a couple months to kind of figure that out.
Well, they had a
Where,
whole, yeah, they had the whole,
yeah,
I mean, they knew in by March that this
yeah,
isn't looking good. And they started renegotiating, figuring this out by, the summer. We're not gonna have scientific sessions. And part of it also was that we didn't really know. We didn't, I
yeah.
mean,
There
like
was so
we
much
even went
uncertainty.
into, yeah, we
Yeah.
even went into the summer saying, well, maybe we will have scientific sessions. We don't know, things like that. But it was just sort of learning how to adapt and going with the flow.
Yeah. Yep. Because I remember, so I was actually in your lab in March of 2020 right before
Oh,
things blew up. The week before, I was
seriously?
working with your research team through industry at the time.
Yeah.
And so the next week was ACC and they canceled ACC. So I remember that
Oh, I
very,
remember that.
they
Yeah.
didn't have time to adapt. So it was a very
Yeah.
quick, like, cancel
Yeah,
it
that
all.
we had that warning because we had all through, almost a year before we kind of could realize, okay, what's going to happen in well, we had March, right, and we canceled our June meeting, right?
Yep.
And then yeah, that was the decision to cancel
Yeah. And
and
then they just
pivot.
went to everything virtual for that whole year and they developed content. Like I think everybody, I know, I was working in industry at the time. And so we all of a sudden couldn't go anywhere, couldn't travel. And we're
I
like, what do
know.
we do? And so we're like developing all this content, like all of a sudden, and doing virtual trainings all the time and virtual demos at the time for where I was at. And so it was a challenging time, like you said, adapting to what we didn't even know we needed to do. So yeah, fun times in Echo for sure.
Yeah, but again, I'm just really proud of. I mean, it wasn't just the ASC, but my own lab. I mean,
Yeah,
the stuff we had, the readers and sonographers had to just do all of a sudden. Oh, PPE, by the way, gown up and dress up, and I mean,
yeah,
we all did it, and under very scary circumstances. We didn't know, we didn't
yeah,
know what was going to happen, and I was really proud. They did it. We're out there in the trenches treating patients in full PPE and during all this.
yeah,
Amazing.
yeah. No, and every hospital across the country in multiple, all across the world really had to really adapt during that time.
Yeah.
So, from walking through that, and the world kind of got put on hold, some of the technology, I think we've still expanded so much in technology even since then. So future, like looking forward to, I know we talked a little bit about AI, but how do you see, strain AI with 3D AI and just multimodality imaging coming together to change valvular assessment moving forward?
Oh, I think it's all good. It is all good. One, we still have, I think, significant gaps in our current technology. We could do better. We could be more accurate and more precise and more reproducible in how we diagnose valve disease. Yeah, we can do it. And I think we pretty much replaced the cath lab. But
The strain.
certainly that's yep. And then certainly that's true for diagnosing aortic stenosis. I mean, we can pretty much tell when the gradient for over, velocity is over 4 meters per second, it's severe, right? So, but we could be more reproducible about that, and that gets that sort of, quality and how to maintain that across labs across the country, just so that one lab's AVA of zero point 0.8 is consistent with my lab's, AVA. 0.8 is consistent with my lab's, AVA. So that, we're trying. I think that's very important for us to be able to continue to do. I do think technology and AI will help us with that. Absolutely.
Yeah.
And so I think that's just, as I said, I believe that that's going to get better. We're going to be better. We're going to have greater reproducibility, greater quality with the help of AI tools. And are we there now? Totally not yet, but I see some promising things happening. And I also think that AI will make the life of a sonographer easier, as well as readers. It will, I think it will take over some of the more mundane measurements that, you're asked to do, and things like that. So you can focus on, sort of more of the complex hemodynamics.
Yeah, and getting your images and getting quality images. So,
Yeah. And
yeah.
I've seen AI, at least in some of the machines, a sort of AI kind of directed image scanning. I mean, I think that's still at the infancy, but I've seen that. So
Yeah.
that yeah.
Yeah, having worked for some industry partners as well, I've seen behind the veil and behind the curtain on a couple things. And so yeah, I mean, I think that the ability is out there to have view recognition and be able to really guide that. But like you said, very much in the infancy stages, and even in the infancy, it works pretty well as long as you have, a clear image. Obviously, if it's a difficult patient, then that becomes a little bit more challenging. But
that's why you will always need a sonographer.
Absolutely. I agree.
You will always need a sonographer. I think the use of the AI technology is to make it more efficient and not have to sit there and draw the lines here and there and things like that.
Yeah,
So
definitely. Yeah. So then, any advice that you have for a sonographer that really wants to deepen their expertise in valvular heart disease? How would they go about doing that?
well, I think you can certainly attend a lot of the educational content that's online, whether it be from ASC or any courses. There are a ton of stuff, and it's so readily available now. And I always like case-based approaches. So I find that's just the easiest way for me to learn from. So just educational content, attending. If you like to travel and attend it, you can go to the meetings as well. And just, I think it's also important to try to get exposure to as many cases as possible. In a place like ours where we get a ton of valve referrals, that's like a dime a dozen here, right? But if you're in a more community-based program, it's important, that perhaps seek those out, and the more you do, the better you get.
Yeah. For sure, experience. And I think one of the things that helped me when, I was first learning echo too was, I wasn't good at the Pedoff probe, the non-imaging continuous wave probe. I didn't have that skill. So how do you build skills like
You
that,
gotta do
right?
it. Gotta do
I
it.
did it every time, every normal. I still did it when I can get it on a normal that I know, over and over and
Yeah.
over again, I know I can get it. And so I just did it every time. And,
Yeah. I'm a little worried that Pedoff is gonna go the way of
eh,
give me an
eh,
example. Uh
yeah,
yeah, but you have to keep doing it to,
yeah, yeah,
yeah. I was always amazed because I would watch uh some of the sonographers who literally had 40 years under their belt, and it was truly a non-imaging probe. They could know when they were in the AS stream just
yeah.
by listening.
Yep.
They
Your
they
ears.
figured it out by listening,
Yep.
and they were right on. They could tell MR from AS.
Yep.
So, and I think that is
Absolutely.
unfortunately a loss. But it's going to be even more important because I think valve disease is going to be increasingly a common thing we're going to be diagnosing by echo. I mean, as I
Yeah.
said, as our population ages, we're going to see a ton of AS. We're going to see a
Yeah.
ton of MS, ton of
Yeah.
MR, and now TR.
Yeah.
So we own it, guys, and we're going to have
Yeah.
to figure it out.
Yeah. And, then we get into all of the different devices, right? So then we have the devices to be able to treat, your triclips,
Absolutely.
all of that. And so your tiers and your mirrors. And so, taking it to that kind of structural heart approach. Obviously sonographers can be involved in that as well. It depends on the lab. Some labs, they might not be as heavily involved in those cases.
Yeah.
But, what is ideally the role of a sonographer in those structural heart cases, typically, at least in your lab?
Yeah, I think we're still figuring that out, right? I think we're still figuring that out as we figure out these structural cases. And I think for our institution, and I think it's sort of mirrored other institution is, the first structural valve was the TAVR valve. And everyone, you had like 30 people in the room. And but I think we're now very comfortable with TAVR valves, and there's a range, and it really depends on your resources at your institution. But I think there's a significant number of institutions, just like ours, where we have a sonographer basically um, uh, scanning during the procedure with backup, and usually with an attending staff at least available or in the room to if there are any issues that come up, right? So,
Yeah.
and that's where TAVR is now, but that wasn't so true, 10 years ago, right? So I think we'll evolve and see what happens with the other type of structural cases, such as the TEER procedures or the catheter mitral or tricuspid valves. I
Yeah.
don't think we're there yet. But I will say though that it's not just during the intervention, right? That's kind of
Yeah.
is the wild part, right? But it's also the pre-assessment and the post.
Yep.
We're gonna have to figure know these things, and we're gonna have to know what an invoked valve looks like, and all
Right.
that anyway. So it's of course the sonographer is gonna learn to recognize these, and they already are. They already. I mean, figure out how to look for leaks on TAVR valves. They're a little different from the surgical bioprosthetics, and they're all gonna have to be experts in this because that's just now um, part of their responsibilities. And it's kind of nice because think of, we didn't even have that 20, 30 years ago.
Yeah.
We were
Yeah.
like
I've been an
barely doing
ultrasound
Doppler.
25
Yeah.
years. Yeah.
So, I mean, it's the
Yeah.
technology is just
Yeah.
phenomenal. And I think it's actually translated to better care. But I think
Hmm.
hopefully that makes it, exciting and new. There's always new things happening. And I think that's also what keeps me going too, as well. It's not just the same old new device practically every month.
Yeah.
And I think
It's true.
but
Yeah.
that's a good thing. I think that
Yeah.
it makes it interesting. And I really do think that, as I said, that technology is going to drive the innovation, and that's actually going to make sonography more efficient more and provide more opportunities for sonographers, because it's not going to just been, oh, you're just scanning things. That's
Right.
it's yeah, it's going to open a lot of different paths.
Yeah, a lot of
I,
advanced
I
understanding.
embrace I embrace technology, because I think it actually opens pathways
Yeah,
for all of us.
agreed. Yeah. And I think also moving forward, I think gone are the days of siloing things into one center. A lot of centers are trying to do more multi-centered approaches and really not housing, there's data registries like the ASE has the data,
Absolutely. Yep.
and so I think that because of those initiatives to share information and to share data and to really build, multi-center compilation of data together, that is also driving technology as well.
Yep.
And so,
Yeah,
yeah,
it's the that thinking where it's, it's not my center versus your center. It's all of us together really does drive innovation, and it improves that kind of collaboration is always better for improving technology innovation and ultimately better care.
so I absolutely agree. I have a question for you. So when you're reading, is it coffee or tea? What's your drink of choice? I
Seltzer.
can't see it. Seltzer.
Seltzer.
Ah, yeah.
If I do more than one cup in the morning of coffee, I'm like vibrating. So after that,
Right there.
I'm down to seltzer water.
Yeah. I do my 1 cup of coffee. If I get to a second, we're all in trouble because then I start having
Yeah,
palpitations.
yeah.
Yeah.
I get really like I start crawling out of my skin. I don't know people. I always admire people who can have that, fifth, third cup in the afternoon. Like so.
Yeah. Yeah. Too much for me. Awesome. Well, one more question that's just kind of random, but one echo myth that you would love to retire forever. Can you think of anything?
Oh, echo myth. Well, let's see. I don't know. What myth do you have about echo that I could
Oh,
retire for you?
I didn't think
I
that
don't
far
know.
ahead. So I think echo myth. I think one of them is that AI will steal our jobs, right? I think we already we
Maybe
already.
I'll address that. I just can't. I mean, that has not happened. And it's going to make our jobs better. We're going to be doing more interesting stuff.
Mhm.
And, with the stuff that's sort of the more mundane tasks, we'll let the AI do. And not only with that, it will actually improve and increase the number of echoes that are needed to be done
Mhm. Yeah.
because we can be more efficient about them. So I think that's a total myth. That's a
Yeah.
complete myth. And
Agreed.
just so,
Yep.
I mean, I say this again. I know this happened in radiology when because I think they've adapted or adopted AI a lot faster than we are, and well, we're catching up and will be. But that myth was there, maybe 10 years. And if you look at the numbers, actually, what actually happened is as they got more efficient and could do more studies, guess what? They're doing more studies. And
Yeah.
now the demand is higher for staffing,
So
and yeah.
yeah. So that brings
So
another question though,
yeah,
because then we're working on sonographer burnout, right? And
yep.
sonographer injury. And
But it's
so
not the scanning. See
yes.
the I think that's the point I'm going to make for you is that I think as technology getting better, we're not going to be asking them to do the drudgery stuff. There's going to be ways, um, other ways that are less sort of hands on. But so the sonographer will be left more as sort of doing the supervision and the analysis.
Yeah. And getting those basic views and then let the software do the analysis pretty much. So
And supervising that analysis.
correct.
Yeah,
Absolutely.
yeah.
Yeah, for sure.
So
Um,
that's where I see it. I don't see it uh, meaning that we're going to ask sonographers to do 20 studies.
right.
Will be they'll be um, they may be doing 20 studies, but they're not obtaining the 20 studies.
Yeah. I have one more question for you. So is it a myth? This is the question of, I don't know if this is a myth or not, right? So trying to figure out, is it a myth or is it truth? So there's a lot of there, when 3D really started first becoming very popular within echo, one of the kind of talk tracks around that, at least from the sales and the industry side, is,
Mm,
oh yeah, you can get your 3D and you can get your full volume heart and not have to take any other pictures other than
yeah,
maybe some, right?
yeah.
So do you think that the full volume 3D will ever replace kind of traditional 2D imaging other than Doppler and things like that, but
Yeah,
your
no, that's a
standard 2D imaging?
that's a great question and very relevant question and very reasonable, right? Um, I so how long has 3D been around? 19. I remember when the first machine rolled into the it
It
was
was Phillips.
1995,
It was
1995,
yeah.
something like
It was a
that, mid
while. It
90s.
was the,
Yeah,
the it was the predecessor to the IE33. I can't remember the name of it, but yeah.
yeah, 5500.
No, it was the one
Yeah,
after that. 7500. It was the 7500.
7500. Okay, yeah.
Yeah.
So, but my point was that we've had 3D has been around a long time. And
Long time.
yeah, and I think where I think the reason it has not been as widely adopted as perhaps we and industry would like is because the image resolution is not as good.
Yeah.
And I think but I think that's going to change. I
I
think
think that
we're
has changed.
Yeah, I actually think because they've been saying that for a long time, believe me.
They have.
1995.
They have.
Yeah, every new probe, oh, this is so much better. This is so much better. You're like,
Right.
yeah, right.
Yeah.
But I actually think with what I've seen of the newer systems, I will
Hmm.
say that it's noticeably different as opposed to
Extremely different.
yeah.
Yeah.
So so I think that's what's limited us. But again,
Yeah.
I think the technology, I will reserve judgment because I've only just seen test cases. But
Yeah.
I actually think the technology may actually be there where we will start using more for 3D, 3D
Hmm.
as a routine. Now,
In the
whether it's, pardon me,
in the transthoracic.
transthoracic, yeah, I think TE and for
Yeah.
transesophageal, it's kind of pretty much there.
Yeah. Yeah.
For transthoracic, but you said, you're talking about, transthoracic, getting a trans 3D image and then going from there. That's I don't think we're there. We're not there yet. The image quality still is not as good as the 2D. So maybe still some combination.
Yeah.
But as I said, I'm always impressed by how the technical innovations that
Yeah.
we come up with.
Yeah, and I'm not going to name any vendor names because I don't want to go there. But at the same time, I've seen some really amazing 3D out in the last few months. So
Yep, I
I,
agree. I
I
agree.
last week there was some amazing 3D. So I'm interested to see how it moves forward for sure.
Well, as I said, I would say that within the last year, I've actually said, wow, this could actually be different
Hmm.
compared to the last 30 years that's been going on. So
Right.
I'm also very excited as well. And I think that, as you said, I think they figured out whatever the physics and the processing power to
Hmm.
really make a big improvement.
Yeah, without having the probe overheat. So it's
Yeah,
always helpful.
I haven't had the probe overheat.
Yeah, that's
So
good.
maybe it doesn't get to me when if that happens. So it's
Yeah.
just
No.
yeah.
It's what it used to do in previous a long
Oh,
time ago. It could only handle the processing power for so long and then it would overheat.
yeah, oh
So
really? Maybe
that's
I just
always been the challenge of 3D ultrasound is how to cool down the probe
huh,
internally and get it to continue to work. And so I think our vendors have figured that out a while ago. So yeah.
great. Yeah. If as I said, I'm very excited to continue to see the improvement in image quality because that's
Yeah.
the issue, right? You get the 3D data set, but when you cut in, the image
Yeah.
quality definitely degrades.
Yeah. It's very hard to pull any other images out of that. So
No, exactly. And I think that's been why it hasn't taken off.
yeah. So you're
But
able to crop in for your valve, but that's about it. Yeah.
but you can't even see the valve sometimes
Not on
after you prep it.
transthoracic.
Yeah. But I think what I'm saying, I think
Yeah.
I think the technology is there to really get that much better.
Yep, agreed for sure. Awesome. Anything else that you can think of that a sonographer could really benefit from in order to just, again, learn echo, move up in echo? Any other advice for that kind of entry
No,
level
I
sonographer?
no, I don't. I'm not going to provide specific advice because I think there are many different pathways, and people are at different stages in uh, but I would say that I think it is so exciting to be in this field. For sonographers, not just as a physician, there's so much innovation, there's so much growth, and so many now different treatments for cardiac and not just valve disease, for just cardiology
Yeah.
in general. So I find it very exciting to be in this dynamic field, and it's not just a pathway of scanning and learning, but there's so many other possibilities that are available to you as a sonographer. So I would encourage folks to go into it. I think it's wide open in terms of what's available for you. And as I said, and when you're done, make sure you come to Boston and apply to our program.
Yeah. Sounds good. Awesome. Well, thank you so much, Judy. I really appreciate you joining me today. This has been a great conversation. Very insightful. So I'm going to go talk to my chickens. So, yeah. Thank you again. This has been another episode of Sonographers After Dark with Dr. Judy Hung. Thank you so much.
Thank you, Lara. It's been a pleasure being on, and I'm so glad you're doing this podcast. I think it's great.
Thank you. Appreciate it. I'll see you next time.